Let's talk about the increased risk for stroke with atrial fibrillation. When blood doesn't move properly, it has the opportunity to clot. A clot forms and it goes to your brain and it causes a stroke. So what happens in a normal heart is blood moves through the 4 chambers of the heart completely normal. The top 2 chambers are the atria, the bottom 2 chambers are the ventricles. So normally, atria squeeze, ventricle squeeze, blood moves where it's supposed to go. In atrial fibrillation, instead of the atria giving a good squeeze, they're quivering, they're chaotic, they're crazy movement, it's not working. The ventricles are still squeezing, but the atria are not. And so when that blood gets stagnant or doesn't move or it doesn't go where it's supposed to, it forms a clot and puts you at very high risk for stroke. And what can happen is most 90% or so of the clots that are formed from atrial fibrillation are formed in something called the left atrial appendage. The left atrial appendage is like a windsock that just hangs off the left atria of the heart. It has 4 different shapes it can be in. It's a windsock, cactus, cauliflower, and chicken wing. That's what we call it when we look at the imaging if we're going to be doing a procedure, which we will talk about that as well. So what do we do about this increased risk for stroke? Well, we quantify it with a tool called the CHADS2 VASC. And what that does is it gives us a number for each patient and their risk for stroke. So we look at several different factors. If they've ever had heart failure or been treated for it, hypertension, diabetes, coronary artery disease, peripheral artery disease, aortic plaque, previous MI. If they are a female, you get an extra point. And if you are 65, you get 1 point. And if you're 75, you get 1 point. And then if you have ever had a stroke, a mini stroke, or a thromboembolism history, then you get 2 points. So the total points you can get are 9, but the important points that we look at, 2 for men, 3 for women. Once you hit that number, then it is recommended that you are indefinitely on anticoagulation for the prevention of stroke with atrial fibrillation. So you really need to have a discussion with your patients and your healthcare provider regarding this so that you are protected from stroke. You also have to look into your risk for bleeding. And I always tell my patients that there is never a right answer or a wrong answer. There's only, well, I guess there could be a wrong answer, but there's only a right answer for them. And once we've had a discussion, because some people feel strongly one way or the other, and everybody gets the right to choose, right? They just have to be given the best evidence and the best conversation so that they are understanding and that you're understanding where they're coming from, and you guys come together and make a good decision. So that is where we start talking about anticoagulation. And right now, oral anticoagulation, we can use warfarin or Coumadin, but we have to watch INRs, make sure that they're within a therapeutic window. There are the direct oral anticoagulants like Eliquis, Xarelto, Pradaxa. Those are the main 3 that we use. I think I talked about them on another TikTok. And some of those have special caveats, like Pradaxa has to stay in its original packaging because once it's exposed to moisture in the air, it loses its efficacy. Xarelto needs to be taken with a high-calorie meal for the best efficacy. Eliquis doesn't. It doesn't matter. You can take it. You just have to take it twice a day. So that's a little bit easier for some patients because people need to use pill boxes or they need to take it out of the original packaging because it's difficult for them to use with their hands or something like that. So that's kind of a quick rundown of stroke risk with atrial fibrillation.